Welcome to SkinSync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Welcome to special conference coverage from the 2026 Elevate-Derm RAPIDS Conference. I'm Victoria Garcia Albea. I'm a dermatology nurse practitioner from outside of Boston, Massachusetts. And I am here with Dr. Yosipovitch, who has itch in his name. He is one of those unsung heroes who has taken it upon himself to master and really dive deep into itch understanding and treatment. So we're going to spend a little bit of time talking about itch, patients that are itchy, how to treat them, how to work them up, and just generally how to approach our itchy patients. So we know that itch is neuroimmune, multifactorial. It is not histamine driven, but why do we still want to prescribe or recommend antihistamines for our patients that are itchy?
Thank you, Victoria. First of all, I don't state that itch is non-histaminergic. It's chronic itch that is
Okay, thank
non-histaminergic.
you. So acute
Acute
itch.
itch is, in many cases, has a histamine. But the majority of itch that I deal with and really cause suffering is the chronic itch. And there, histamine has a really limited effect. So we know that the nerve fibers that transmit chronic itch are non-histaminergic. They're mainly what we call PAR2, proteinase activating receptor 2, and possibly also PAR1 in some cases, and they don't respond at all to histamine. So the fact that we give antihistamine to these patients is really unnecessary, except if a patient is sleepless nights and you want to sedate him, so you give him sedating antihistamine, but there are better drugs that can address that than sedating antihistamines that have a lot of side effects.
Right. So if you have a patient with chronic itch, what do you recommend for a workup? What blood test do you do? Let's say there's no rash and you don't see obvious inflammatory skin disease. Is there a recommended set of labs or workup that you do for these patients?
So I don't do a $1 million workup because it's unnecessary. I mean, first of all, it's good to hear from the patients history taking just to be sure that there's no like weight loss or any systemic symptoms, HV sweats, or that kind of leads you to think about like lymphoma or other, conditions where there is a cause. I do basic lab, which includes CBC and differential, do CMP, liver function testing, creatinine, because sometimes nowadays, just to for the audience is to know that once I thought only dialysis patients have chronic itch. Apparently, now we know that stage 3, 4 of kidney is associated. So if you have a creatinine of 2.4, it could be a cause of kidney-related itch. The same as actually with liver function. Sometimes patients who have fatty liver can have itch, and we always just thought that cholestatic. These are basic, just to rule out hyperthyroidism, because that could be an expression of itch. I do in cases a chest x-ray and an ultrasound just to rule out if there is any underlying malignancies.
Is it an abdominal ultrasound?
An abdominal.
Thank you.
Or in some cases, a CT scan just when you feel that there is some kind of, because remember, these are cases in the 80s. Part of the diagnosis was like for patients was a pruritus itch. And we kind of forgot about it in the last couple of years.
HIV?
And also HIV
Yeah.
testing, a very common thing in patients with HIV is chronic itch with not low CD4 counts. Interesting.
Are you doing a pretty thorough history, including travel? Like, do you think about
Excellent.
parasites or?
Sure. I mean, scabies includes about 400 million patients a year. And I
Wow.
can tell you, we a lot of times miss scabies, including
Yes,
myself.
me too. I always feel so bad when I do that. Do you go home every night and douse yourself in permethrin after you see all those
No,
itchy
no, no, no,
patients?
no. But just to let you know that in the era of biologics now, I didn't mention in my talk
Mm,
that they change how scabies looks like. The type 2 cytokines, they fight parasites. My word
mm.
of caution is I've seen already patients who've been on dupilumab and nemolizumab that the rash has totally changed and looks totally different with these drugs with scabies. So do try not to give drugs like dupilumab for scabies patients.
Try not to miss scabies.
That's the good.
Talk about BNP. That was something I wasn't familiar with. You mentioned it in your lecture that you'll sometimes do a blood test for that level.
Yeah. Unfortunately, insurances don't cover it.
Okay.
So I write that the patient has swelling of his legs
Well,
because
we
of the
could use
legs.
it in
Yeah,
our patients
right.
who do have swelling of
Right,
their
of the
legs.
legs. But BNP is brain natriuretic peptide, and it's been associated with congestive heart failure and cardiac disease and kidney diseases. And what we've shown was that it is actually a neuropeptide highly associated with itch of different types, in particularly itch in elderly, itch
Mm.
in patients with CPUO, chronic pruritus of undetermined origin, where elderly commonly suffer, also in patients with prurigo nodularis, even in patients with atopic eczema, they have elevated BNP. The question is, how is it as a biomarker? At the moment, I can't say, but we've seen that in some patients, it correlated very well with itch intensity. And would say that in the future, we'll see if you could have this as part of a armamentarium of assessing these patients.
Another, I don't even know. What's periostin? What is it? A
Okay, so
molecule?
periostin is a protein, an
Okay.
extracellular matrix protein, but is highly associated with type 2 inflammation. It is secreted by fibroblasts and keratinocytes, but what we've shown that it amplifies the itch scratch cycle. And the more you secrete periostin, the more you get the type 2 cytokines. The more type 2 cytokines secreted, the more
Mo-
periostin. So it's kind of an amplifying, but what we learned from a colleague of ours in a school of veterinary medicine was that this periostin doesn't do just the amplification of type 2 cytokine, but it has a direct effect on nerve fibers by its effect on alpha beta integrin receptor, causing itch. So it's a double whammy kind of inducing itch.
And you mentioned that it's found in nodules of prurigo
Right.
nodularis.
It's found in these patients with prurigo nodularis. Correct. And it
So,
highly correlates. It was the highest correlation, and it's been now in the literature and validated by other groups that it correlates extremely well with PN itch intensity.
do you think it's something that might be coming eventually as a treatment, like an
Excellent.
anti-periostin?
Yeah. Antiperiostin or its receptor
Mm.
would be an amazing drug because it has two effects also on the neural component and also directly on the type 2 cytokine. So that could be, in my opinion, a very exciting area. What we've seen is when you block in mice, I have big respect more to the human part, but in mice studies, when you block it, the mice stop itching.
And how did they block it in the mice?
So there are or the receptor, the
Mm.
integrin, or the periostin itself.
Okay. So we know that yawning is contagious. Is itch contagious?
100%. So we've shown initially there was a study in humans in Germany by a colleague of mine, Uwe Giller, who was a psychodermatologist, who showed with a German TV that they showed to healthy subjects pictures and videos of ants crawling and insect bite, and people started scratching themselves. In any of my talks, I sometimes see people start
Yes.
scratching themselves. So this is not new, but what we've done was almost 20 years ago, we thought that maybe patients who have chronic itch are more susceptible to these visual cues. And indeed, what we showed them, we showed pictures for atopic eczema of patients with itching or just sitting idle. And we induced with saline. We told them that we're inducing itch to them. And the patient, when they saw the patient scratching in the video, we didn't know, but we were recording
Yeah.
them on a screen documenting their scratching behavior. And what we saw was a robust activity, and we compared it to healthy subjects. So this is a phenomenon that occurs in every healthy and in atopics. But what we saw was that the atopics were more susceptible to these
Mm.
visual cues, and they started scratching in areas where they didn't have itch at all, suggesting that there is a brain mechanism associated. That led us later on to look where in the brain this phenomena happens. We had the hypothesis, which we found was totally wrong. We thought it's like mirror neurons that are then reported in the prefrontal cortex in yawning. So we thought, oh, this is similar to yawning. Apparently, totally not. It does involve a reward and striatum and areas that are amplified in the scratching mechanism. So we think that by visualization of some other patient, seeing them scratching, the brain translated as more itch, and that's how it kind of amplified this. So I'll tell you another story. I had a dermatologist who wanted to give me, he's the world Guinness holder of back scratchers.
What?
He has more than 1,200 back scratchers from all over the world.
Where does this person live? What country?
And in the
In the
US, in
US.
North Carolina, and Fayetteville. And he wanted to donate his collection to my clinic while I was directing a center at Temple. And then, second thought was that if I'll put all these back scratchers in the clinic, it would actually
Make
induce
people more
more
itchy.
patient itchy and scratching. So I thought that it's not a good idea.
Well, they should study you because you must be resistant to becoming itchy from watching people scratch.
Uh,
They should study you.
Interesting.
Talk about your topical concoction with ketamine and amitriptyline for, I'm sure, specific subset of patients who are itchy.
So ketamine, amitriptyline, lidocaine, that's a
Lidocaine,
concussion, and
okay.
I'll give exact formulation. So people would, I give first of all, the initial reports came from the Mayo Clinic, but they only use ketamine and lidocaine or amitriptyline. They only use a very minimal concentration, and I developed a more stronger concentration, and I feel comfortable in doing that
Mm.
from experience we've gained is a 10% ketamine, 5% lidocaine, and 5% amitriptyline. We've inserted in a very good vehicle that enables it to penetrate well to the epidermis it's called lipoderm base. This is only achieved in a compounding pharmacy. I'm more than happy to share where I work for a long time with a pharmacy in Philly,
Mm.
or a young pharmacist at the time. He's not a young anymore. He finished pharmacy school, and at the time he heard that there's a dermatologist in Philly who wants to compound because very few dermatologists compound. And I was looking for compounding pharmacies, and he said, I don't want to work in the big pharma, Walgreens, whatever.
Yeah.
I want to develop myself a
Uh,
compounding pharmacy. And since then, we really have worked with his team. But I have to admit that there are other compounding pharmacies in the US. But I'm just saying, this led to a real good collaboration with compounding pharmacies. And I have to admit that it helps a lot of our patients because it's the most robust antipyretic and also anti-pain it
yeah.
has drug that I can provide as a topical.
And do you worry about side effects of ketamine
Excellence. As I
and
mentioned
even
in my talk,
amitriptyline, the
yeah,
sedation?
right. Overall, the amount of systemic absorption we've tested at
Mhm.
too is very minimal, but I do not recommend using it more than 20% body
Mhm.
surface involvement at one time. Second, do not recommend swallowing it, as one of the patients did that and
Oh,
did
gee.
ketamine cause a dissociative state. And this patient was able, after swallowing the cream, to get that. So this is the real ketamine.
Did you borrow this concoction from veterinary medicine or you just came up with it?
No, it's been in the field of neuropathic pain, so it's been used there. There are also systemic ketamine that we've tried, not for these indications, where there is really bad neuropathic
Mm.
itch. We were the first to do that, and later on, my former fellow and now a dermatologist himself and has an itch center, Dr. Quattro, validated it in
Wow.
a study. So we used the IV ketamine that is given for post-traumatic pain and also very complex neuropathic pain. And we've shown that it does work for some forms of neuropathic itch. However, this has systemic effect and dissociative. So
Yeah.
it's totally different from the topical.
Okay.
To ta- kind of dissect that this is totally different
Yep.
from a topical formulation. Is that it?
Absolutely. Yep.
That's clear.
That's perfect. How about, or like, where does topical capsaicin fit into your toolbox? Do you
Excellent.
use that? I find I have to really counsel patients about not putting too much on because it can burn.
Led to studies more than 30 years ago. One of my first study was using capsaicin with amla for patients with itch. Why do you do that? Because actually I thought that it would reduce that burning sensation because initially with capsaicin it liberates substance P and it burns more and it activates that TRPV1 pathway. But the idea was to reduce that by giving amla before. I wasn't aware that actually EMLA at that time could have an add-on effect
Oh.
because it does block sodium channels, and
So,
sodium channels have a role also in itch. So actually, that combo is better than using just capsaicin.
okay.
So that's a good idea to do. The problem with capsaicin that's why I don't use it so often is now that the ketamine lidocaine trip is stronger and faster. Because with capsaicin, you need to know that there's no gain without pain. So you
The
have to
longer you
have,
use
yeah,
it, the
you
better.
have to do the first 2 weeks very high concentration
Okay.
in order to reduce that burning sensation faster.
And do you have trouble getting patients to adhere for that
Yeah,
couple of
that's a
weeks?
problem. But if patients could adhere, it
Mm.
works very well because it really destroys the nerve fibers in that area. And that is part of the issue that we want to destroy the nerves transmission of itch. So it works, but
You gotta counsel
with
them.
the worst thing is to apply it near the eyes. You have to be very
Oh,
careful.
yeah.
Or genital areas, just a word of caution. I did a lot of research with it. It would penetrate through my gloves. I
Wow.
get burnt like hell.
Okay.
So
It's
it's
like after you cut
important.
a jalapeno and you touch your
Right,
eyes, you
correct,
know.
correct. And
Uh,
we did an interesting, just to let you know,
yeah.
one of the interesting studies was that we found that skin of color, African Americans don't have any effect with capsaicin. My recommendation is not to give them,
Don't try it.
not
It's
at
not gonna
them,
work.
because it doesn't work with
Fascinating.
interest. I have a different story, but
I
we
really
could
liked
get
your
in trouble.
global study on itch. I thought that was quite an undertaking. 50,000 patients,
They're not
subjects,
50, these are 50,000 subjects that
subjects.
they called, that it reflected city dwellers, villages. So it's a company that understands all the kind of populations in the world, their ethnicities, skin color. They take in account everything. So it reflects really the general population, rather a
Mm,
patient population.
mm.
I didn't mention in that talk that when they looked at those who had reported of eczema, hand eczema, and psoriasis, clearly they had more itch than higher than the 40%.
Sure. I think lastly, I would love to hear a little bit about how staph and scabies produce proteases that trigger itch.
Hmm?
And it made me think it must be protective so that when we were cave people, I like to tell my patients, we would scratch the scabies mite out of our skin. And that's how I think of where itch evolved from.
Excellent.
How do you think about that and talk to
So
your patients about it?
clearly, itching was a protective measure. I believe in the fauna, you're right, that the animal would see someone, and that's also related to the contagious,
Yeah.
is that one animal would see that animal scratching. I should stay away from that area. So I think it is a signal of
Yeah.
protection. Unfortunately, when it becomes too, you suffer from it. So I believe that also hairy areas are more
Mhm.
susceptible to itch. That's something that we have also looked into. And the hair follicle, you need the hair follicles to itch more. So a
Fascinating.
bald person is less itchy than
That is so
a
interesting. Well, any last words to summarize, your time here? Anything you want us to really take home from your presentations?
is that there's a new future for itch, itchologs or anyone who's interested in itch, that there are better treatments for itch, and we're advancing. The field is advanced significantly, and I feel that we're still in a learning phase of better understanding what's going on, but it's an exciting time.
Okay. Hashtag itchalogs.
Itcholog.
Thank you for joining us.
My pleasure.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.